Thank you, sir, for supplementing that. Now I would like to request our next presenter, Dr. Noreen Amin, to update us on Unveiling Roxadustat, latest insights on CKD anemia management.
Honorable Chairperson, respected teachers, esteemed panel of experts, and my dear colleagues, Assalamu alaikum, good afternoon. I am Dr. Noreen Amin, Research Assistant, NICDU. Today I am going to talk about Roxadustat and share some lights based on latest guideline and recommendations by Asian Pacific Society of Nephrology. Anemia is a common complication of chronic kidney disease. In CKD patients, hemoglobin concentration less than 13 gram per deciliter in male and less than 12 gram per deciliter in female is considered as anemia. Anemia of kidney disease is linked to left ventricular hypertrophy, heart failure, decreased quality of life, and faster progression of disease and death. Regarding the pathogenesis of anemia in CKD, there are several factors. It could be due to reduced oxygen sensing in the kidney and reduced erythropoietin production, chronic inflammation resulting in increased hepcidin, and iron deficiency. The current management options of anemia are iron supplementation. It could be by oral or IV form, ESA therapies, blood transfusion, and the newer therapy is HIF-PHI inhibitors. The treatment challenges of current management are ESA hyporesponsiveness, blood transfusion compromising future transplantation, functional iron therapy, and chronic inflammatory status. Before going to main recommendation, I would like to brief about HIF pathway, which is a hypoxia-inducible factor pathway, plays a central role in erythropoiesis. It affects all the key components of erythropoiesis, like increases the erythropoietin production, suppresses the hepcidin production, and increases iron absorption, transport, and mobilization. In normal condition, this pathway is not activated, and the HIF-alpha subunit is degraded by an enzyme called HIF-prolyl hydroxylase enzyme. And there are some worldwide HIF-PH inhibitor drugs are available. They are the Roxadustat, daprodustat, vadadustat, molidustat, erythropoietin, and decidustat. Roxadustat is a HIF-PH inhibitor that mimics the body's natural response to hypoxia by activating the HIF pathway. Roxadustat inhibits the enzyme, thus preventing the breakdown of HIF-alpha subunit, thus activating the HIF pathway and induces the transcription and translation of genes, resulting in increased RBC production and increased hemoglobin level. It promotes a coordinated erythropoietic response by increasing the endogenous erythropoietin production, by increasing the iron mobilization, and downregulating hepcidin level, resulting in increases hemoglobin level and endogenous RBC production. These are the common adverse effects of Roxadustat: hypertension, 13.9%, vascular excess thrombosis, 12.8%, hyperkalemia, 10.9%, and peripheral edema, 11.7%. Roxadustat is contraindicated in hypersensitivity to drug itself, pregnancy, mostly third trimester of pregnancy, severe hepatic impairment, and in case of breastfeeding mother. Now the recommendation from Asian Pacific Society of Nephrology. As HIF-PHI was first approved in various Asia-Pacific countries, these APASN HIF-PHI recommendation committee were formed by a panel of 11 nephrologists. They had clinical experience or been investigator in HIF-PHI studies, reviewed and deliberated on the current and preclinical evidence to better understand the potential benefits and the harm of the medication. It is a review article published in the journal Nephrology by APSN, published on 21st November 2020. Volume number is 26, issue number is 2, page number 105 to 118. Now the recommendations for alternative to ESA. Physicians can consider HIF-PHI as alternative to ESA in correcting and maintaining hemoglobin level for renal anemia in CKD patients. Which group are suitable? It is suitable for both dialysis-dependent and non-dialysis-dependent CKD patients. Regarding iron supplementation, iron status should be evaluated before the drugs are used. It is advised to correct iron deficiency before initiation of the drug for all CKD patients. The target level ferritin should be more than 100 nanogram per ml and transferrin saturation should be more than 20%. Now recommendation for specific groups. Before prescribing HIF-PHI, the presence and risk of malignancy should be ascertained. And in case of known malignancy patient, administration should be undertaken only with great caution. Retinopathy is a theoretical concern of HIF-PHI in CKD patients. Early referral for ophthalmologic assessment is warranted in patients who report visual disturbance after drug initiation. Regarding the liver dysfunction is relatively uncommon in CKD patients receiving HIF-PHI, although regular monitoring of liver function may facilitate early detection of drug-induced hepatic dysfunction. The data on hyperkalemia as an adverse effect is inconclusive. However, considering it can be a medical emergency, it is suggested that serum potassium being monitored in patients receiving HIF-PHI treatment. And regarding hypertension, clinical studies have no signals that suggest a hypertensive effect of HIF-PHI, but as ESA use is associated with hypertension, so one should pay attention to blood pressure control in patients treated with HIF-PHI. Now, pulmonary hypertension and heart failure. Clinical studies have no signals that suggest aggravation of pulmonary hypertension or heart failure by HIF-PHI, but one should pay attention to the changes of cardiac function in patients treated with the drug. Recommendations for thrombotic events. Clinical data and basic studies raise the concerns of thrombotic events in HIF-PHI treatment. Limited use of the drug is advised in the patients with any history of thrombotic events, or a careful use of the drug is advised in patients with cardiovascular disease. This is a table showing thrombotic and severe events in dialysis-dependent CKD patients. Here, all cardiovascular events are significant in patients who receive treatment with Roxadustat. This is a table showing thrombotic events in non-dialysis dependent CKD patients. Here, only congestive cardiac failure cases are seen. This table shows adverse drug reaction of clinical interest in patients with non-dialysis dependent and dialysis dependent CKD patients. Here we can see that deep vein thrombosis was higher in percentage in patients who received Roxadustat in both non-dialysis dependent and dialysis dependent CKD patients in comparison with patients with placebo. Regarding polycystic kidney disease, one should follow the sizes of cyst up when the drugs are used. Seizures and neurological complication. Clinical studies have no signals that suggest seizure or neurological complication as an adverse effect. Now the potential benefits. It is shown that Roxadustat has decreased LDL level more efficiently than the other placebo. Now the current status of HIF-PHI drugs. Roxadustat is currently approved in China, Japan, and Chile. And it is authorized in the European Medicine Agency for the use in the European Union. But FDA Cardiovascular and Renal Drug Advisory Committee voted against the approval in July 2021, suggesting increased cardiovascular toxicity. Whereas daprodustat is approved by both FDA and EMA for dialysis patient in USA and Europe. Vadadustat is approved in Europe for the dialysis population, but not approved in USA. All these three drugs have been approved in China and Japan. Now, suggestions for the clinical practice. The indication to use HIF-PHI in both non-dialysis dependent and dialysis dependent CKD patients are same, like patient preference for oral treatment, ESA hyperresponsiveness, chronic inflammatory states, and patients who receive home dialysis can also use the drug. This drug should be used with caution in case of vascular excess with high risk of thrombotic complication, retinal disorder, autoimmune diseases, history of cured malignancy, or without recurrence for at least 5 years, and kidney transplant recipients. The drugs should be avoided in patients with a cardiovascular or thrombotic event in the previous 3 months, history of malignancy in last 5 years, polycystic kidney disease, proliferative diabetic retinopathy, macular degeneration and retinal vein thrombosis, and idiopathic pulmonary hypertension. During administration, please ensure adequate iron store prior to initiation the treatment. The ferritin should be more than 100 microgram per liter, and transfusion saturation should be more than 20%. Achieve and maintain target hemoglobin level of 10 to 12 gram per deciliter. During monitoring, avoid rapid rise in hemoglobin more than 2 gram per deciliter over 4 weeks, or very high hemoglobin level like more than 12 gram per deciliter. Monitor hemoglobin level at least monthly until the target hemoglobin level. Monitor potassium and liver function tests. These are the reference articles. Thank you.